Yeah, I guess once you see these abnormal findings, what's your conversation with the patient to just lay out treatment options?
Yeah, I think often I'll try to, in my head, determine what's the, sort of the cause. What do I think is the most common cause? And my discussion will follow that logic. So the patient has a big ovarian vein, but it looks like it's refluxing. Then we'll go down the reflux discussion and sort of just mention that there is this other thing and or these other things, iliac and renal vein compressions, and we would work those out, but we're not sure. This is where the pre-procedural imaging actually helps a lot. I think we need to do this, or at least think about this more. But if you can do an ultrasound ahead of time and see that there is a iliac vein compression, but when you sit the patient up, that iliac vein compression gets a lot better. When you stand them up on ultrasound, it gets a lot better. Or if you do the ultrasound on the iliac vein compression and don't see acceleration of blood flow through the iliac vein compression, or you don't see retrograde flow in the ipsilateral internal iliac vein, these may be findings that make you think that the left common iliac vein compression is not important. And the same logic can be used for the left renal vein in terms of looking at its anatomy and its physiology on ultrasound and using criteria that are in the literature, sort of have a lower pre-venography probability of those lesions being important. And that can focus your conversation with the patient. Also, the clinical presentation will focus your conversation a bit. So if you have a woman who comes in with chronic pelvic pain and she's 18 and never had any children, your conversation is going to be different than with somebody who's had 5 or 6 children, as we talked about earlier, and has evidence that the reflux on anatomy from the imaging is the main problem. Postmenopausal women tend to sort of lose any venous origin pain from reflux as they get older. It's not a hard and fast rule, but that seems to be true. And certainly even the varicosities in the pelvis, if you look at age quartiles, if you will, of patients, the diameters of the veins reduce after menopause. And so a postmenopausal woman who gives a history of pain since she was premenopausal and has a very significant iliac lesion and the reflux seems to be there, maybe more of a patient you would lean toward a conversation toward the iliac vein discussion. But it's always important to put in the context of the patient, the other possible physiologic issues, and recognize that there may be obviously findings during a venogram or even after embolization that may necessitate treating both conditions in a given patient.
So if the patient presents with pain and they have positive findings on, say, ultrasound and MRI, even with these dynamic maneuvers on ultrasound in clinic, do you still let them know, look, I'm still going to be checking with a venogram before I place any metal, before I place any coils, before I place a stent, I'm still going to be checking. It's still something I need to confirm while we're in the procedure before I actually treat it. Are you telling them anything like that?
No, we definitely say that we're going to confirm. I think the more information you have beforehand will also influence how aggressively you need to confirm. So if you do a CT or an MRI or transabdominal ultrasound and you see the left common iliac vein has minimal compression, I think minimal confirmation is probably needed at the time of the procedure. Same with the left renal vein. But if you have somebody with compression that looks significant and you happen to even have physiologic evidence that compression is significant, retrograde left iliac vein, internal iliac vein flow, acceleration of flow in the lesion itself, similar for the left renal vein, if you have physiologic evidence that it's more significant, then you'll be more aggressive and you'll certainly put a little bit more emphasis in the conversation with the patient that some of these things may need to be addressed, or maybe that's the only thing that needs to be addressed.